Hello and welcome. This is the critical thinking video that accompanies the IM660 module on shock. Specifically today we're going to be doing a case that relates to the differential diagnosis of shock. We're going to be talking about how history and physical helps inform this differential diagnosis, what workup we need to do. There'll be a little bit about treatment that's also sprinkled in, but more specifically related to the case. Before we get started, let's do a quick practice question. The answer to the practice question will be immediately following the end of the video. So without further ado, let's get started.
Which of the following types of shock is characterized by a loss of sympathetic tone, leading to hypotension, bradycardia, and warm extremities? A. Septic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Obstructive shock.
This is a 65-year-old man who presents to the emergency department via EMS after collapsing in rehab. The patient was discharged from the hospital a week ago after having a CVA, resulting in right lower extremity weakness and some confusion. He was admitted for 3 days and required a urinary catheter for retention. He's supposed to follow up with urology this week, as well as vascular surgery for evaluation for carotid endarterectomy related to his stroke, but was too sick to go to his appointment yesterday. Per his wife, he's not been acting right for the last 2 days and has become progressively weaker and more short of breath. He was checked for COVID-19, which was negative, and placed on amoxicillin for an upper respiratory infection. His appetite's been poor, and nursing reported to his wife that he's been vomiting and has had complaints of indigestion and chest pain. He has had one other unwitnessed fall, but nursing reports no injuries to the wife. He has a past medical history of the stroke, obviously, but also hypertension, diabetes mellitus, polymyalgia rheumatica, hypothyroidism, and osteoarthritis. He's got a surgical history of cholecystectomy. He quit smoking 5 years ago, otherwise no alcohol or illicit abuse. His family history is only positive for heart disease. His medications, he's on several, like lots of patients, including aspirin, clopidogrel, simvastatin, metoprolol, minoxidil, lisinopril, levothyroxine, Umex, prednisone, meloxicam, metformin, and linagliptin. On physical exam, his blood pressure is 82/43 with a 98 heart rate, respiratory rate's 24. His oxygen saturation is 92% on room air, and he's got a temperature of 100.1 Fahrenheit. In general, the patient's lethargic. He's awake to touch, but he's in moderate distress. His mucosa is dry. He's got some mild JVD. Cardiovascular exam shows regular rate and rhythm without murmurs, rips, or gallops. Respirations are diminished to auscultation bilaterally. His abdomen is soft, non-tender, non-distended. His neurological exam shows global weakness with difficulty lifting both his arms and his legs. His extremities shows no clubbing, cyanosis, or edema, but more specifically on his skin exam, with a closer look, he does have delayed cap refill, but his extremities are warm. On GU exam, you note the Foley catheter that's also present with dark urine. So since we're talking about shock today, the first thing we should probably decide is this person in shock? One of the main ways we do this is by the patient's blood pressure. Typically, a systolic of less than 90 or a drop from 40 from baseline can indicate shock. Generally, a mean arterial pressure of less than 65 also indicates shock. The less than 65 is probably the more common way in which people judge hypotension. So to know if the MAP is low, we first have to understand how to calculate it. 2 times the diastolic added onto the systolic and then dividing that by 3. For our patient specifically, this would indicate a mean arterial pressure of 56, which would certainly indicate shock. Sometimes your blood pressure can be high initially in shock due to catecholamine surge. This is one of the reasons we measure lactates to judge shock in patients with sepsis. Next, we'd probably look at the patient's heart rate. Generally, we'd expect the patient's heart rate to be tachycardic. In this circumstance, our heart rate's only 98, which is close to 100, but wouldn't necessarily represent tachycardia. So why would this be in this patient? Looking through his medication list, we can see that he's on metoprolol, which suppresses the patient's heart rate. This can also be true when patients are elderly. Sometimes they can't meet their own metabolic needs and have falsely low heart rates when related to shock. Tachypnea is another sign due to lactic acidosis from hypoperfusion. To balance out a patient's pH, they'll expel extra CO2. Poor skin capillary refill can be another sign of shock, which is also present in our patient. Patients can have urinary findings. In this case, it's lucky the patient has a Foley catheter. We can see the patient has dark urine. This can be in response to vasopressin release, which increases fluid conservation. Another nonspecific indicator of shock can be mentation. Hypoperfusion to the patient's brain can cause lethargy, can cause confusion, but this can also be caused by multiple other causes. Now that we've established our patient is in shock, let's take a minute and think about the differential diagnosis for the patient. If you need to, feel free to pause the recording, gather your thoughts, make a little list for yourself, and then you compare it to the list that we come up with together. In general, the cardiovascular system can be thought of as a plumbing problem. First, we can think about pump failure, which would indicate cardiogenic shock. A differential for this includes things like myocardial infarction, valvular abnormalities, arrhythmias, both brady and tachy. Some of the stranger things that fit into this would be things like hypothyroidism, as well as iatrogenic overdoses, beta blockers, calcium channel blockers, digoxin, amiodarone, other antiarrhythmics. In our same in our same plumbing analogy, we think about the tank being empty. This would indicate hypovolemic shock, which can be things from hemorrhage, which can be from trauma, gastrointestinal bleeding, triple A rupture, as well as ruptured ectopic pregnancy, which wouldn't relate to our patient but could still be possible. Things like severe dehydration from gastrointestinal losses, nausea, vomiting, diarrhea, burns from the skin, as well as kidney sources of fluid loss from diabetes insipidus, diabetic ketoacidosis, as well as diuretics. Capillary leak also contributes to hypovolemic shock. This can be in septic causes, which also overlaps with our distributive causes, which is the next category, but also things like pancreatitis can cause capillary leak. No tone in the pipes would indicate a distributive cause of shock. As I said earlier, sepsis is going to be the most abundant of this category, but other things like anaphylaxis, neurogenic causes due to vascular loss of autonomic tone, and then adrenal crisis, which is due to loss of cortisol, which helps regulate vascular tone. There's a secret fourth category about this in our plumbing analogy related to the pump being blocked, which would be an obstructive cause. This would be from pulmonary embolism, a massive one, cardiac tamponade, as well as tension pneumothorax. So now that we have a differential diagnosis, let's try to cross this with some epidemiological facts. Hypovolemic shock is going to be the most common overall type of cause of hypotension, and distributive, specifically sepsis, is going to be the most common in an ICU. So let's compare our differential diagnosis to our patient specifically. Could this be a case of cardiogenic shock? Well, the patient's diabetic, they're hypertensive, they're having chest pain, they are obviously a vasculopath as they've had a recent stroke and need a carotid endarterectomy. So, MI and shock related to pump failure could certainly be high on the differential. The patient also has history of hypothyroidism, seems like they've had a recent illness. Sometimes this can be a nidus for the onset of myxedema. Could this be a hypovolemic cause of shock? Blood loss could certainly contribute to this. The patient's on a couple of new blood thinners, presumably they're new. The patient also takes chronic meloxicam, which can be a risk for peptic ulcers, which can be exacerbated by being on blood thinners. The patient's recently had some falls. They could be bleeding internally. The patient has history of emesis as well as around Bumex, so dehydration goes up the list. The patient also has history of diabetes mellitus and is complaining of vomiting, so those are two different signs and symptoms related to diabetic ketoacidosis. Could this shock be of a distributive cause? Well, sepsis, as we said earlier, is the most common cause, so that's pretty high on the differential. The patient complains of a recent upper respiratory infection, but could this actually be a lower respiratory infection? Those tend to be bacterial and one of the more common causes of septic shock. The patient has a Foley catheter, which can present as a possible nidus for urinary tract infections. The patient's also recently been hospitalized, which increases the infection rate. But what about the idea of anaphylaxis? The patient recently got introduced to amoxicillin. Was this the first time they've had this medication? This could be some questions we could tease out on further review of systems. Neurogenic could possibly be a cause too. The patient's had some recent falls. Um, Patient takes chronic steroids for polymyalgia rheumatica. Did this get missed between changing facilities? If the patient had been on chronic steroids and suddenly discontinued them, then adrenal crisis would be high on our differential. Finally, could this be a case of obstructive shock? The patient was recently hospitalized. They've had mobility problems, so pulmonary embolism would go up the differential. If you look at the patient's medication list, minoxidil's listed, which is a very potent vasodilator, which also has the complication and side effect of pericardial effusion, which can lead to tamponade. The patient's been having some falls recently. They're also complaining of chest pain, so the possibility of having a tension pneumothorax is also on the list. So now that we've got a pretty robust differential diagnosis, let's ask some further questions that can help refine our differential. So we should ask some questions specifically about the chest pain the patient's having, the nature of it, point to a pneumothorax versus if the patient's having an acute MI. We should ask if the patient has been having any dyspnea on exertion, they've been falling, but is that possibly related to syncope? All these make the idea of cardiogenic causes of shock more likely. The hypovolemic category, we should probably quantify the amount of vomiting the patient's had. If they had one episode of vomiting, that's likely not the cause of the shock. But if they've been vomiting 10 times a day for the last week, that would make it more likely. For gastrointestinal bleeding, we should probably ask about hematemesis or melena. For diabetic ketoacidosis, we'd expect the patient to be complaining of some abdominal pain as well as polyuria, polyphagia, polydipsia. For distributive shock, we should try to tease out a little bit more about source of infection, since sepsis is the most common cause of this. Is the patient having any suprapubic pain? Are they having any flank pain? Are they having any abdominal pain? Have they been developing any wounds in bed or skin changes? Are they having sputum production? Related to anaphylaxis, we should try to ascertain when the amoxicillin was introduced, if this is a new medication for the patient, how close to dosing of this medication, such as hours to minutes, did the patient start having symptoms. For neurogenic, we should look for spine pain specifically, and then asking anything you can get your hands on, whether it be a med reconciliation or talking to the family about, or the facility that they came in from, about if the patient's been missing any steroids, since they've also been vomiting. So has the patient been tolerating their medications? For obstructive shock, characteristics of the chest pain, again, as I mentioned earlier, as well as speed of onset, pulmonary embolisms tend to happen quite quickly. Now moving on to physical exam. We've already established this guy's in shock and probably in trouble due to the nonspecific findings that we outlined initially to prove the patient is in shock. But let's move to some specific findings. The patient has a low-grade fever, so that we naturally would think infection, but that can also be present in adrenal insufficiency as well as myxedema. Pancreatitis and pulmonary embolisms can also have fevers. The patient has jugular venous distension, which can be a sign of pneumothorax, massive pulmonary embolism, as well as cardiogenic shock, but can also be present in patients with tamponade about 76% of the time. Pulsus paradoxus would be something to go out of your way for and actually check a patient. It's an exaggerated drop in blood pressure during inspiration, which has an 82% sensitivity in patients with tamponade. Normally, this is less than 10 millimeters of mercury. Abnormal findings are greater than 10 to 20. For neurogenic causes of shock, we would generally expect the patient to have bradycardia, but we should also look specifically for spine pain on the patient. If you did find an area of spinal pain, looking for flaccidity and areflexia below the area would be important. As opposed to septic shock, which causes peripheral vasoconstriction, neurogenic shock tends to have warm pink extremities and good pulses, unlike our patient. Now for some initial treatment. We're, of course, going to do a very thorough workup and a thorough physical exam. We're going to talk to EMS, we're going to talk to family, etc., for history. But in cases of shock, some initial treatment can't wait. Ventilation, infusion, and pump. VIP are the little moniker that goes along with treatment in shock. So ventilation and oxygen support. The patient's lethargic, so we should probably make a quick determination if they can protect their airway. If they can't, they would need to be put on a ventilator. Maybe they would need a blood gas to make sure they're not hypercapnic, as this can contribute to the patient's lethargy. As far as oxygenation goes, their SAT appears well on room air, but it does have a slight fever, which shifts the oxygen dissociation curve to the right. So controlling that may increase the patient's oxygen carrying capacity. This is just a fancy way of me saying that we should give him some Tylenol for his fever. For infusion, we should begin fluid resuscitation. A shotgun way of doing this is starting the patient on 30 cc's per kilogram of isotonic fluid. This would be 0.9 normal saline or lactated ringers. If it turns out that the patient has a disease process that is not amendable to fluid resuscitation, such as massive pulmonary embolism or pneumothorax or cardiogenic shock, we can always take fluid off of patients later via diuresis. If we had a high suspicion of any of these disease processes, we could always be judicious with our fluids with 250 cc fluid challenges every few minutes, monitoring the patient's response. For pump, vasoactive agents or pressors, we would want to initiate something like this after the patient had failed fluid resuscitation. An undifferentiated shock, norepinephrine, or Levophed would be the pressor of choice. So let's begin our workup on this patient. What workup should we order? We're doing this for two main purposes. We're looking for end organ dysfunction related to the shock, and then we're also looking for causes of the shock that our workup points to. So let's start with some blood work. Starting with the patient's complete blood count, we would want to look for severe anemia that would require transfusion. Thrombocytopenia can be a sign of sepsis as well as DIC. Leukocytosis or leukopenia can be signs of sepsis. On a basic metabolic panel, hyponatremia can be an indicator of cardiogenic shock with fluid overload or can be part of an endocrine process such as adrenal insufficiency or myxedema. Hypernatremia can indicate things like diabetes insipidus as well as free water deficits. Acidosis on a basic metabolic panel can be indicative of poor perfusion, such as lactic acidosis or ketoacidosis for diabetic ketoacidosis. An elevated BUN to creatinine ratio of greater than 21 can indicate a pre-renal AKI, which likely is caused by dehydration or hypoperfusion. Looking at a complete metabolic panel with the addition of liver function testing and AST, ALT being severely elevated can indicate shock liver. Lactate production or an elevated lactic acid level can indicate anaerobic metabolism. It could be a sign of end organ dysfunction. If we want to do specifically an endocrine workup for this patient, we might consider doing a TSH or free T4. TSH is elevated, drastically or vastly elevated, and a T4 is almost nil in myxedema. We would want to do cultures related to a specific area of infection. In non-specific infection, we would start with blood cultures. If we had a specific source, such as pneumonia or urine, we would want to gather cultures as needed. If we wanted to consider bacterial sepsis, we could do a procalcitonin level. Also, related to endocrine disease, we could check a cortisol level or do a STIM test. Although, if you suspect adrenal insufficiency, you should probably treat it before testing for it. We should also do some imaging for this patient, starting with an electrocardiogram. Electrical alternans can be present in pericardial effusion, although the sensitivity is only 25%. Signs of ST segment elevation would indicate a myocardial infarction. S1Q3T3, new onset right bundle branch block, can indicate massive pulmonary embolism, as well as an EKG can detect arrhythmia if present when the EKG is being conducted, both Brady and tachy. Chest X-rays can look for pneumonia as a possible bacterial source. They can look for tension pneumothorax. They can look for pulmonary edema as a sign of cardiogenic shock, as well as maybe guiding fluid therapy. They also have some nonspecific signs of aortic dissection. If you're handy enough with it, a bedside echocardiogram or ordering a formal echocardiogram can be completed. It's pretty easy to see if a patient has large pericardial effusion, which may indicate tamponade. Massive pulmonary embolism have signs of right ventricular dilatation, hypokinesis, as well as McConnell's sign and septal motion abnormalities. Again, if you're good enough with an echo, you can see the patient's ejection fraction. You look for wall motion abnormalities. You can look for valvular heart disease, as well as hypovolemia can be indicated by small chamber size. Otherwise, imaging can be guided based on your differential diagnosis and informed by a review of systems and physical exam. For example, if you were doing a physical exam on this patient that's fallen multiple times and found C-spine tenderness that was midline, then perhaps you'd want to order a CAT scan of the cervical spine to look for fracture. Now that we've completed our initial workup as well as our initial treatment, we talk to the family, we do a deep dive into his chart, we look at all his rehab records, maybe we call the facility. We find out that the amoxicillin's been there for a week and he's taken it before, making anaphylaxis less likely. He's had no bleeding. But the last hospital did mention that the patient was anemic and might need a transfusion soon. But he, like I said, denied any epistaxis or melena or hematemesis. You do notice that prednisone isn't on his MAR at the facility. Turning to the patient's initial lab work, we can find a CBC showing a white blood cell count of 18, hemoglobin of 6.9, and platelets of 79,000. So leukocytosis, some pretty severe anemia, as well as thrombocytopenia. The patient has an elevated lactate of 5.0. Coags are slightly elevated with an INR of 1.7, and his TSH is within normal limits. On his complete metabolic panel, the patient has a sodium of 136, potassium of 5, bicarb of 16, BUN 48, creatinine 2.1, glucose is 212, AST, ALT are both moderately elevated. His alkaline phosphatase is normal, his bilirubin's 1.1, and his albumin's slightly low. So what kind of interpretation can we make from this? The patient doesn't have any hyponatremia or hypernatremia. They looks like they've got some acute kidney injury that appears pre-renal. They're acidotic. Their potassium's on the high end of normal, which likely is being driven by the patient's acidosis. Their glucose is elevated, but probably not high enough to indicate diabetic ketoacidosis. Their LFTs are elevated. Sometimes this happens with hypoperfusion to the liver as early as shock liver. Albumin's low. This can be an acute phase reactant with third spacing of albumin in patients with distributive shock. So, and our INR being 1.72 with a combination platelets of 79,000, we would worry about early DIC. We complete our imaging for the patient. We'll say the EKG was unremarkable. We do a bedside echocardiogram, which shows no tamponade and a normal ejection fraction. We complete a chest x-ray, which shows some right mid-lung pneumonia. So now that our workup's completed and putting the whole patient picture together, they've got lab work that indicates a severe anemia, likely requiring transfusion. They have signs of sepsis as well as septic shock on physical exam, as well as lab work. We're finding end organ hypoperfusion in the liver as well as the kidneys, and some acidosis that's related to elevated lactate. So what should we do with this patient? We found a pneumonia on chest x-ray additionally, so we should start him on antibiotics directed for hospital-acquired infection as he's in septic shock and was recently hospitalized. He's recently had a stroke, so aspiration would also be a consideration, a possible cause for the infection. So piperacillin tazobactam with the addition of vancomycin would be broad-spectrum antibiotics geared toward nosocomial gram-negatives, including Pseudomonas as well as MRSA. The patient's hemoglobin's low, so we should transfuse him 1 unit of PRBCs. Since he hasn't been on his steroids, adrenal insufficiency would certainly be still in the consideration. The patient's not hyponatremic. The sugar is actually high, which we would expect it to be low in patients with adrenal insufficiency. But just to be on the safe side, we should probably start him on stress dose steroids, which involves hydrocortisone 100 milligrams IV and then 50 milligrams IV Q6 until the shock resolves. Stress dose steroids are also indicated for patients with refractory shock in sepsis additionally. The patient failed the initial 30 cc per kilogram IV fluid bolus, was started on norepinephrine, which was eventually titrated to a maximum level. The patient required an additional pressor. Adjunctive therapy in this case for septic shock would be vasopressin. He was eventually intubated due to respiratory failure. He remained on a ventilator for 3 days but was successfully extubated. Speech therapy saw him after extubation, was noted to have severe dysphagia. Surgery placed a percutaneous endoscopic gastrotomy tube or PEG tube for feeding. The patient was discharged to a rehabilitation facility 10 days after his initial presentation to the hospital and completing his antibiotics. But given the 40% mortality associated with septic shock and his recent stroke, he's probably lucky to be alive.
Correct answer. C. Neurogenic shock. Neurogenic shock results from a loss of sympathetic tone, typically due to spinal cord injury, leading to unopposed parasympathetic activity. This results in hypotension, bradycardia, and warm extremities due to vasodilation.